I just want to say a little introduction and a little welcome and a prayer, and then we'll get started. My name is Kurt Heineman. If you do not know me, I'm one of the co-pastors here at the church. Mary Graves is the other co-pastor here at the church, so it's a warm welcome extended to everyone who's here today. And we are delighted to have this panel discussion today. This is wonderful for us. As a pastor, I do not know so much about the information that these wonderful people do know, but I spend quite a bit of time in the hospital setting with people and with families and loved ones at the bedside when they're in the hospital. And that's always a tender time as a pastor, getting to journey with people in those scenarios and in those places. I'm welcomed into a space that not a lot of other people are welcomed into, and it's very meaningful to be present in that space as a presence of giving witness to who God is in this place. So it's always a delight for me to get to pray there, because that's what I feel like I end up doing, is giving witness to a larger story that's taking place in the context of the hospital room. And I'd like to read for us one of the Psalms that I read when I often visit in the hospital setting as our opening prayer this morning. It's Psalm 123. Let's pray together. I'm sorry, Psalm 121, not Psalm 123. It says this: I lift my eyes to the hills. From where will my help come? My help comes from the Lord who made heaven and earth. He will not let your foot be moved. He who keeps you will not slumber. He who keeps Israel will neither slumber nor sleep. The Lord is your keeper. The Lord is your shade at your right hand. The sun shall not strike you by day, nor the moon by night. The Lord will keep you from all evil. The Lord will keep your life. The Lord will keep your going out and your coming in from this time on and forevermore. Amen.
Hi, everybody. I'm Dr. Lucy Kalanithi, and I'm really excited to welcome everybody to this panel today. I'll just tell you quickly who the other panelists are, too, and how we're going to structure the panel. And I think I'll just say, it's really exciting to be able to do this panel here, because the people up here are members of this church, which is really exciting. It's sort of like, in my opinion, it's like a world-class panel about cancer. And I think part of the message there is two things: what an exciting community this is, but also within the church there are lots of resources. So if you or your family is affected by cancer or grief or confusing questions about healthcare or whatever, feel free to come chat with people, including me, down the line, and I'm sure the people here would have similar thing to say. And we're not the only people in the church who are experts either. For example, Mary Kaufman is a hospice nurse coordinator at Kaiser. Lori Taylor is a support expert in the church who was immensely helpful to my family when my husband was dying. And so anyway, just feel very, very welcome to reach out to any of us in the future. So I'm a physician at Stanford, but today, the people on the panel will all be sharing our expertise, and part of my expertise is family experience with cancer, and I know a lot of people in here have similar unfortunate expertise. But I just wanted to read, before we got started, a piece of writing that my late husband did about cancer and the moment that he got diagnosed, to sort of bring in some of what Pastor Kurt just called tenderness to this discussion, which is so human and personal, and about like some of our biggest life questions. So we're going to be talking science today, but of course it's all embedded in like a really big emotional, spiritual life and death experience, of course. So I just want to read maybe like 3 paragraphs and then we'll get started. So this is my husband, Paul, who was a neurosurgeon and writer who died about 4 years ago of lung cancer when he was 37. Really unexpected situation, obviously. I flipped through the CT scan images, the diagnosis obvious. The lungs were matted with innumerable tumors, the spine deformed, a full lobe of the liver obliterated. Cancer widely disseminated. I was a neurosurgical resident entering my final year of training. Over the last 6 years, I'd examined scores of such scans on the off chance that some procedure might benefit the patient. But this scan was different. It was my own. I received the plastic arm bracelet all patients wear, put on the familiar light blue hospital gown, walked past the nurses I knew by name, and was checked into a room. The same room where I had seen hundreds of patients over the years. In this room, I had sat with patients and explained terminal diagnoses and complex operations. In this room, I had congratulated patients on being cured of a disease. In this room, I had pronounced patients dead. I had sat in the chairs, washed my hands in the sink, scrawled instructions on the marker board, changed the calendar. I had even, in moments of utter exhaustion, longed to lie down in this bed and sleep. Now I lay there, wide awake. A young nurse, one I hadn't met, poked her head in. The doctor will be in soon. And with that, the future I had imagined, the one just about to be realized, the culmination of decades of striving, evaporated. This is in my husband's writing, and When Breath Becomes Air. And I think that moment of you get diagnosed and you're the same person you were 5 minutes before, and you're also a totally different person. The future you had imagined evaporated. And so I think this panel is going to be about what do you do medically as you're thinking about what's available in terms of treatment and how to get your bearings, and what are some of the new innovations in cancer. So let me just say two other things to kind of set the tone for what we're going to talk about. We want to share with you some of the new vocabulary in cancer. I think everybody thinks of cancer treatment that we've known for a long time: chemo, surgery, radiation. But if you read the news, or if you've had a recent diagnosis, there are new words and therapies to think about, like targeted therapies, molecular diagnosis, immunotherapy, and some new testing and treatments otherwise. So those are some of the things we're going to share today. And tied up in those new innovations is easier and better treatments and much, much more hope, and sort of a new way of thinking about this disease that is really evolving. And it's a wonderful time to be a cancer patient now. That's a weird way to say that. But if you have to be a cancer patient, it's an exciting moment. And it's also even more uncertain than it was before, which is its own tricky thing. But anyway, we'll welcome you into some of this new stuff. And I just want to say who the panelists are quickly, and then I'll stop talking. So Dr. Lynn Seeley is sitting next to me, and she's a physician who works in really innovative biotechnology startups. So she'll tell you what she's doing. Dr. Kenji Obadia is a scientist who is working on specific testing that leads patients to treatments like immunotherapy. Max Dean is a radiation oncologist at Stanford who also does research on something called liquid biopsy and treats patients. And then Dr. Amy Moore, everyone up here is either an MD or a Ph.D., or in Dr. Dean's case, both. Dr. Amy Moore is a scientist who works at a patient organization, at the Go-To Foundation for Lung Cancer, which is incredibly supportive to people in our community. And in a stroke of luck is literally like one of the country's leading organizations on lung cancer, and happens to be like right down past the Shell station on Britton Ave. So I'm going to ask each panelist to answer 2 questions for about 5 minutes each. Then we might do a little bit more talking about clinical trials, and then we're going to do Q&A, like maybe even for up to half an hour. So hold on to your questions for what you might want to ask, and we'll also be here after. So each panelist, 5 minutes-ish on a little quickly who you are, and what your expertise is that you work on, so people know the science, and then what is the one or maybe couple pieces of advice that you give to a loved one who has just been diagnosed? Like, what's the real practical thing that you say to your own loved ones with cancer? So, Dr. Seeley.
All right. Is this on? Well, thank you, Lucy. I have to say, I can listen to you talk all day long. So,
and
hurry up.
I will say, if you see me checking my cell phone, it's just for a time check. And actually,
Right up there.
take it back. Okay.
And I'm I'm super honored to be here on this very intimate panel because, of course, we all know there is no more difficult topic. And I thought I might start by just sharing with you a little bit of my journey. I am a physician. I'm also a CEO of a biotech company. How did that come to be? It's a little bit of an unusual story. I started my training in internal medicine, which is the study of chronic diseases that are treated with medicines, not surgery. And then I specialized in endocrinology, or the study of hormonal diseases like diabetes and thyroid disease. But at the same time, I became a scientist. I went back into the laboratory and learned about cell systems, and I studied how cells signal to grow and divide and how they use fuels for their energy and their metabolism. And I was very happy on faculty at the University of California, San Diego, pursuing a career in academic medicine. I was teaching, I was seeing patients, I was doing research, and that's what I'd always intended to do. And I got invited by serendipity to give a basic science talk at a biotechnology company. I didn't actually even know anything about biotechnology companies, but I thought that would be interesting and fun to learn. And for those of you who don't even know what a biotechnology company is, because I didn't, it's very simple. It's companies that are focused on the latest and greatest technology and coupling that to biology, or the study of living organisms, to develop new treatments or medicines to improve life or prolong life. And so, interesting. I went. I was just amazed. I met these incredibly well-trained scientists and physicians working in teams with engineers and manufacturing experts trying to develop new medicines. And I suddenly realized as a physician, there might be an opportunity to do something quite different that might impact thousands or hundreds of thousands of patients instead of treating one patient at a time. And after a lot of soul searching, I decided to make the leap. They recruited me, and I joined this company working on a variety of different things. And as this is the fourth biotechnology company I'm working at now, but my third one, I had a really interesting experience where I got to develop a new targeted therapy for prostate cancer. And actually, it was one of the earliest targeted therapies. So what is a targeted therapy? In the old days, we all want cancer to stop growing. We want the cells to die. And so we were using rather broad approaches to achieve that. But the days of targeted therapy means we really understand a tremendous amount of the biology of that specific cancer, and we target that particular pathway to slow the growth and ideally kill the cancer. Well, in prostate cancer, we learned that men with very late stage prostate cancer, men who'd failed all treatments, their prostate cancer was still driven by male hormones like testosterone, and that if we could design a very targeted therapy, very potent, to block that male hormone or testosterone pathway, we thought we'd be able to benefit men. And fortunately for us, we were successful and able to do that, and we took this drug all the way through clinical trials and got it approved. And so men who previously were going to hospice with nothing else then had an opportunity to live longer with many fewer toxicities than patients previously before it had with a pill, one pill or just one oral treatment a day. And so this generation of targeted therapies has really sprung up. I've been running clinical trials now for many years, trying to develop new medicines. My current company, which I started about 3 years ago, is developing a new targeted therapy for prostate cancer, and is also very focused on bringing targeted therapies to women's health, which is not the topic today, but I'd be delighted to talk about that another time, to really benefit women with diseases like uterine fibroids and endometriosis. So there is a new day in oncology treatment, which you're going to hear about, it was quite different. And that's why if I have one advice to give to people who are newly diagnosed with cancer or struggling with it, it's terrifying and overwhelming, even for people who are extremely knowledgeable. But for somebody who's not, it really is just such a shocking emotional experience that the first thing I recommend everybody does is find an advocate or more. Scan everybody you know, your family, your friends, your colleagues. Find somebody to help you navigate, to find that patient-centered physician who's really going to listen to you, who has expertise in your particular form of cancer, and then to help you come up with your questions, to help you with research, and actually to go with you to the appointment so that they can hear and record because it's so much coming at you, it's hard to hear. And I'll tell you the last thing that I think is so important is that what you once knew about cancer care, what all of us knew about cancer care, is changing. It's changed dramatically over the last 20 years, the last 10 years. It's changing every year. And so I lost my mother to breast cancer. She died very young at the age of 50. Well, very recently, my sister was diagnosed with breast cancer. And she doesn't want treatment because she saw what happened to my mother and the very difficult treatments that she had to go through with toxicities and complications and side effects. And so it's been a real process to educate her and help her understand it's way different today. There's way better ways, way better targeted treatments, and ways to manage the side effects. And so really put away everything you knew in the past and learn anew. There is great hope.
Much. Dr. Obadia is a scientist at Illumina. If you could tell us what you do and what your advice is.
Thank you so much. It's a great pleasure for me to be here to talk to you all and share my expertise. I work for biotechnology before I work in hospital. So I am that guy who is always at the background. When you come to the hospital, you're not going to see me, but we help the doctors in making those diagnoses. So for now, I'm mostly focused on molecular diagnosis. And if you look at diagnosis of cancer in the past, let's just go back about 10 years ago. A patient comes, we do one test. So if we want to test for lung cancer, liver cancer, and all the like, we have to do like 10 different tests, each on its own. But now, with advancement in technology, we are able to take one sample from a patient, and we can screen for up to 512 biomarkers and genes for cancer. That's what I'm currently working on. And we are currently trying to get that for FDA approval. This is a big revolution in terms of diagnosis because we don't only say which cancer you have, but we are able to say if you can respond to a particular treatment. Now, each individual is different in terms of your genetic makeup. They can give me, just take antibiotic for example, they can give me this penicillin and I don't respond to it, but another person will respond to it. It's the same with cancer too. Even though you say it is lung cancer, if you go and look at the cells, the mutation could be a little bit different. So in the lab, when we use a technology called sequencing technology, so we're able to sequence the gene just from one sample, and we're able to say that, okay, this particular patient, has this type of cancer, and that this patient can respond to this particular immunotherapy. Now, we look at certain biomarkers, and if the biomarker is elevated, it shows that you'll be able to respond to immunotherapy. We'll talk about immunotherapy and the immune system. Now, if, let's say, some enemies come in here, we'll try to fight them. But if it's somebody that's friendly, we'll not try to fight it. That's how your body is. Something that gets into it that's foreign, your body will try to fight it. But the thing with cancer is that it is your own DNA that is replicating, or your own cells that's replicating very rapidly. So your immune system doesn't fight it because it's part of you. Now, what happens is that we look at certain biomarkers. Now, if that biomarker is elevated, it shows that you are able to respond to a particular immunotherapy. Now, what advantage is this? Now, looking at the cost, it's also cost beneficial. They don't just put you on treatment that is not going to work for you. And it gives a lot of hope, especially with a treating physician, to know that, all right, this is a patient that will respond to this particular type of therapy, and this patient is not going to respond to this kind of therapy. So in a nutshell, that's what we do. I'm there at the background trying to do all this diagnosis. So when I look at the future of cancer diagnosis, probably in the next 10 years, we should be able just to collect a blood sample. I know somebody will talk about liquid biopsy. Collect a blood sample, and from that blood sample, we just screen using one test, and we're able to say all type of cancer that you probably have. And we can screen it early enough so they can put you in treatment, and you should be able to get better. So if I may give one advice to somebody who is diagnosed with cancer is to know the details of your diagnosis. I always say it's very important for you to be informed, know what is going on. Which type of cancer is it? Just begin. What's the name of the cancer to begin with? Which part of the body is it affected? Is it a slow-growing cancer, or is it an aggressive cancer? Just that information alone, knowing that it's a slow-growing cancer, is relieving. to you. Knowing that it is aggressive, all right, it makes you a little bit nervous, but you could always discuss that with your physician. And also knowing which treatment options are available for you out there, all right, and the toxicity of the various treatment that are available out there. So that would be my own little advice. Just know the details of your diagnosis. Thank you.
Thank you so much. So testing the type of cancer cells that you have and developing treatments that instead of even chemo infusions, maybe just a daily pill that will keep the cancer under control. And one of the ways to do that, as Dr. Obadia was saying, is changing your own immune system so that it fights those cancer cells like they're a foreign invader or even almost like an infection compared to the rest of the cells in your body. So really exciting treatments that are more effective and potentially much easier to take than previously. Some of them can effectively really suppress a cancer for years and years. Some of them work for a period of time and then stop working. So there's some challenges in making those as effective as possible. And that's some of the next research coming up. Dr. Dean, take it away.
Great. Well, it's very nice to be here today to share some of the exciting advances in oncology and cancer research. I am, like Lucy, a professor at Stanford Medical School. I am a physician scientist, which means I both practice medicine, but I also run a cancer research laboratory. On the clinical side, I am a radiation oncologist, which means I specialize in treating cancer patients with radiation therapy. And particularly, I subspecialize in lung cancer, so I almost exclusively see patients with lung cancers. And radiation is one of the original types of cancer therapy, and you can really think of it in a way as sort of kind of like surgery. The goal is to eradicate cancer cells that we can see or we know where they are, but instead of cutting them out, we are killing them in place. In the clinic, I also do clinical trials. I run a number of clinical trials, and of course, the only way that we can really advance treatment for our patients is to run trials where we test new approaches and prove that they are beneficial. We can have many great ideas that look great on paper, but many things that look great on paper don't end up working, and the only way we can advance cancer medicine is through the clinical trials. So I do quite a bit of work in trials, particularly trying to start trials based on some of the discoveries we're making in my laboratory. So on the laboratory side, I focus on an area called liquid biopsies that Kenji just mentioned. And that refers to a new set of tests that have been developed in the last 5 or 10 years that are really revolutionizing how we can analyze and detect cancers in patients. A biopsy, that term you might be familiar with, that generally means getting a piece of the cancer, getting a piece of tissue either through a needle biopsy or through a surgery. But a liquid biopsy means you're analyzing a biological liquid, mainly blood or urine, those two, and looking for traces of the cancer in those fluids. The advantage of those is that they are, of course, a lot less invasive than a surgery. You can just do a blood draw or give a urine sample. And the power is also that we can repeat those many times easily. A surgery, generally, you may do once in a patient's course, but a blood draw you can do every week if necessary. And so these liquid biopsies are revolutionizing many ways that we are thinking about personalizing treatment for our cancer patients. Really, the underlying revolution in cancer medicine is that we have a much deeper understanding of cancer, so that now we can really personalize treatment to each patient's tumor. In the past, it was more of a one-size-fits-all treatment. You needed either surgery or chemo or radiation or the combination, but really we treated patients with a given cancer really always the same way. Now, we understand it's much more complicated, and we really personalize the treatment to patients. So I treat lung cancer. Lung cancer used to be maybe 2 or 3 diseases, we thought. Now we know it's many dozens of actual diseases, and different subsets of lung cancer need different treatments. And so the liquid biopsies and the diagnostics that you heard about from Kenji is what allows us to identify exactly what kind of cancer or subtype of cancer a patient has, and then to give them the best treatment that is going to work best for their cancer. And so the liquid biopsies, what we focus on in my lab is we look for DNA from the cancer cells in the blood. DNA, of course, is what's in the instructions inside our cells that tell our cells how to work and that tell our bodies how to form. But in cancer, these instructions have mistakes in them called mutations, and those mutations is what causes the cancer. That's what causes the cells to misbehave, to keep growing when they shouldn't, and that ultimately is what can be fatal. And so we look for those mutations. They are really very specific markers of the cancer. Only the cancer cells will have those mutations. None of the patient's normal cells will. And so when we see those pieces of DNA that have those mutations, we can be sure those come from the cancer. And what can we do with that? Well, so we can envision we might be able to actually detect cancer early. So if one gets a blood test in a patient who doesn't have cancer, if we find mutant DNA, that might be a sign that there is a cancer hiding somewhere. And so these tests could someday allow us to diagnose cancer early before it has spread, when it is easiest to cure. We can also use these tests to help us identify what mutations the cancer has. As we've heard about the targeted therapies, those often require knowing what mutation a patient's tumor has to know which of the target therapy is the right one. So within lung cancer, we have probably on the order of 10 almost different pill forms that are targeted therapies, but they target different mutations, and a given patient's cancer will generally have either none or one of those 10, and we need to know which one. And so with the liquid biopsy approaches, we can, in many cases, identify which mutation the patient's cancer has, and therefore which drug they need, just from a blood test, not needing an invasive surgery or procedure. So that's something we're already doing in the clinic on a daily basis. That is prime time. That's not in the research phase. We do those tests all the time. Now, I'll cover one other thing that we are actively working on in my lab, but I'm excited about, and I think will revolutionize how we treat patients with earlier stage cancer, so before it has spread, which is that we think we can use these tests to identify who has been cured and who has not been cured after they've had their surgery or radiation for an early stage cancer. So by early stage, I mean a cancer, let's say, that's in the lung, but that hasn't spread anywhere, that we consider that cancer curable potentially, usually by surgery or radiation. But we know that in a subset of patients, the cancer eventually comes back. And what we are working on in my laboratory is to develop tests that we could do after the patient's surgery or radiation to see if there's any evidence of the cancer still left in the body. Do we still see any of these mutant DNA fragments? If we do, we have evidence that the chance of cancer still being there is basically 100%, and that the patient still has cancer, and therefore likely that right after surgery, when we see that trace of the cancer, would be the best time to treat them with some of these new treatments like immunotherapy or targeted therapy, because they have the smallest number of cancer cells in their body they will ever have. Versus patients where we do that test and it's negative and we can't find any of the cancer, those patients likely don't need any further treatment. And where in many cancers we now give chemotherapy or other treatments after surgery, we know many patients don't need that because they've already been cured, and we think these tests will help us identify those patients as well and allow them to avoid chemotherapy and the toxicities and costs that come with that. So that's just a brief overview of the area of liquid biopsies and I think the exciting way this will allow us to personalize treatment for our patients. And then lastly, my advice to cancer patients, and I'll echo what Lynn has said, is that I think it's critical to find a cancer physician who you are comfortable with and who practices patient-centered care, which means that they involve you in the treatment, you and your family members. They take your values and your goals into account, because cancer care has gotten extremely complicated. Many things are not black and white anymore, where there used to be one option, now there might be three. And which option is correct really depends on what the patient wants, what the patient's needs and goals are. And so I think that's critical, to find a doctor that you have rapport with and that will treat you in that way. And then lastly, just one plug for considering participating in clinical trials. The only way, as I mentioned, to move really the science and understanding forward and to be able to cure more patients is to do the trials that test whether or not these new approaches work. So if you have the opportunity to participate in one, I would urge you to consider that.
I might just add on to that, because I think it's really important to understand that the advances made in the lab, where we start to understand which mutations are really driving the cancer in a very precise way, then the biotechnology companies can work to develop new medicines to really attack those pathways and to bring benefit. But then work that's going on in diagnostics and the liquid biopsies, now we can test patients to make sure before you get exposed to any treatment that you have that specific problem, so that now that's where this personalized medicine comes through, that if you're in a clinical trial, we can target something much more specifically to you to increase the likelihood that you're going to respond. And that's this advances across sectors, whether it's in science or the diagnostics or in the medicines, are all working together to revolutionize and really rapidly change the way we're treating patients.
Great, thank you so much. By the way, I always laugh at the phrase liquid biopsy because it literally just means blood test for cancer, where it does, like instead of doing a biopsy where you take a sample of a tumor and look at it, this is a blood test. So it's liquid because it's blood and biopsy because you're testing it. And I just think it's like, I don't know, unnecessarily complicated. Also, it sounds kind of creepy. Anyway.
That term. It can be too, so.
Oh yeah, good point. Okay, anything liquid, any liquids you want.
Hi, everybody. So I'm Amy Moore, and as you may know, my family just moved out here from Georgia last June, so we are new to the Bay Area. But my background is my Ph.D. is in microbiology and immunology, so I worked on viruses for my Ph.D., and that really stimulated my interest and curiosity in cancer because with the work I was doing with viruses, we uncovered a role for a cancer gene in mediating the interaction of two virus proteins that I studied. And I was like, well, that's odd. What's this leukemia gene doing in the context of my virus? And my husband, we met in grad school at a virology conference. So we were the ultimate geeks. We fell in love at a conference. But so this was part of the story was we both intended to stay in academia, and we realized that nobody would ever need two people exactly like us because, you know, that's kind of weird. So I was following my scientific curiosity with the cancer piece, but also trying to create some diversity between us in case we stayed on the academic path. So there was personal interest and then also strategy involved. But for my postdoc, I moved into cancer research and studied molecular mechanisms of acute myeloid leukemia development at Vanderbilt. And so very much, you know, enjoyed being at the bench, but, you know, we went through the process of interviewing for faculty positions, and we had that two-body problem people call in academia where, you know, we were trying to find two faculty positions at a time when federal funding was in a state of decline, and it was challenging. So, you know, I ultimately did some soul searching, and I, you know, asked myself, what do I really want to do with my life, and what are my strengths? And, you know, that's where I think as a scientist, I had to put aside my ego. And I said, you know, even though I like science, I enjoy bench work, I'm not going to be the one who cures cancer. And, you know, there's a way for me to be part of a larger conversation and perhaps influence more lives. And the way I decided to do that was moving to the nonprofit sector. So about 11 years ago in Georgia, I became part of a statewide cancer initiative that had been founded by a former governor as well as a man named Hamilton Jordan, who was Jimmy Carter's chief of staff. And what they did at the time was to leverage our state's tobacco settlement dollars. So in the late 90s, the states kind of sued the tobacco industry and got these windfall settlements that many states just said, oh, we're going to balance the budget, we're going to pave the roads. But Georgia at the time, Georgia, you know, hands up. We were a little forward thinking to say, we want to do something to help cancer patients. We were one of the largest states at the time not to have an NCI designated, National Cancer Institute designated cancer facility. We had high rates of disparities because we had, you know, really pockets of deep poverty, rural populations, high minorities. So there was an opportunity to do something, and the way that we sought to address it was first and foremost by recruiting top talent to our state. So we went out and aggressively recruited leading scientists to our academic institutions. So we were really focused on building up the infrastructure to support innovative research, and that was my role, was to help do that. We also recognized one of the rate-limiting steps in cancer research is having access to specimens. So we created a statewide biorepository to collect samples from cancer patients and make those available for research. So I did that for many years and then merged into an organization that continued that work, but also created companies around the technologies emerging from our laboratories. So all that was Georgia. And then had the opportunity to move out here with my husband's company. He's still in viruses, so. And stumbled into an opportunity here in San Carlos with a lung cancer foundation. At the time, it was known as the Bonnie J. Adario Lung Cancer Foundation. Some of you might be familiar with it. We just went through a merger with a DC-based lung cancer foundation called the Lung Cancer Alliance. We are now known as the go-to foundation for lung cancer. So we're a bi-coastal national advocacy organization. And much of the work that we do, we are patient-founded, patient-focused. We are there as an education and support network to help patients who are facing a diagnosis of lung cancer. But then the beauty of the merger is because we have a presence in DC, we also have a very strong political piece. So we, I'm going to be on the Hill, Capitol Hill, on my birthday, July 23rd, advocating for increased funding for research. So we do that legislative piece as well and petition for, continued, sustained, increased funding for not just lung cancer research, but all cancer research. So it really is a nice, model. And, that's been, I think, one of the great parts of me coming out here and joining this organization is even though I know the work I did in Georgia had an impact on cancer outcomes and improved lives, it was kind of abstract because we're recruiting people and we're outfitting laboratories and buying equipment, but daily we have patients come through our door and we work with them. We pick up the phone, we're talking to patients. Much of what I do is overseeing our research portfolio, and a lot of that work is done in direct partnership with patients. So as Max talked about, for lung cancer, it's no longer, we used to think of it as a big pie of lung cancer, and now we keep carving it into smaller and smaller pieces by molecular mutation. So we're carving it into so many slivers, and there are these patient groups have formed for each of those different mutations, and those patients are having a voice and having a seat at the table now, and they're helping drive forward research that will benefit not just themselves, but patients overall. And so I work closely with them to help ideate around what are the opportunities, what are the research projects that will help the community. They help fund it, they raise money. So it's very rewarding, gratifying for me to have that and to see the direct benefit of the work we do. And it's a reminder too, I see so much hope, but then, just lost a couple of patients a couple of weekends ago. So it keeps it very real and reminds us, daily kind of why we're doing what we do. So, the benefit of me going last is I can just simply say ditto, for everything that they have just said. But, you cannot underestimate the importance and value of identifying advocates, and an organization such as ours is tremendously valuable for patients. I see it regularly. So that's, seek out people who can help you, and there's no shortage of people who want to help. So find who they are, not just, I'm in lung cancer, but obviously I can help do that. So I'm more than willing to, talk to people. The molecular testing piece, we talk about that so often. In lung cancer, that's hugely important. And that's not happening universally. To us, it seems so obvious that if we can, help you determine the mutation that's driving your cancer, why wouldn't you get that test? Why wouldn't you have that information? Why wouldn't people make that available? It's not available across the board. There's a lot of education that has to be done, not just for patients, but for providers as well. And so we're working aggressively on that front. Clinical trials, it's interesting. My husband's uncle was just diagnosed with lung cancer, within the past couple of months. And so I was talking to his wife, and even with me having all the resources that I have available, the response was, I don't want to be a guinea pig. Why would I do that? And I'm like, no, this isn't just I'm getting the drug or I'm not getting the drug. People think it's I'm getting the drug or I'm getting placebo, and I don't want that. That's not what a clinical trial is, and we can help clarify that for you. The other response immediately was, well, I know there's new drugs, but I can't afford that. I don't want to burden my family. And so, again, we know that there are resources available. There are organizations that help with those kinds of things. Clinical trials can make that available for you at reduced to no cost. So there's a huge education piece involved, but I think the main takeaway is there's incredible hope. It is a weird thing to say that, there's never been a better time to have cancer, but if you look, the statistics say that since 1990, we've seen over a 25% reduction in cancer deaths. There are many things that we're doing right. The treatments are improving enormously. As scientists, as researchers, we go to conferences, the hope is palpable. I mean, you can see it, you can feel it, and so it's very encouraging, and we're here to talk about that more.
Great, thank you so much. I'm going to answer the questions myself too, if that's okay, because a couple things came into my mind. So I'm an internist. I don't have a specialty in cancer research or cancer treatment, but part of my job is cancer screening. So I just want to mention that for people, for you, for your family. If you're an average risk person, like you don't have a strong family history of a certain type of cancer, the routine screenings are mammograms for women every 1 to 2 years, starting at age 40 or 50. As you can see, that's a kind of moving target, so you talk to your doctor about what works for you. Colonoscopy or FIT test or sigmoidoscopy, so colon cancer screening at age 50 on. Pap smears for women it's something like 3 to 5 years now. Once you're over age 30, and a little more frequently than that, younger than that. And also discussing with your doctor whether prostate screening makes sense for you, prostate cancer screening. So if you haven't had a check-in with your doctor about that recently, make sure you're asking about whether you're up to date on those. And then I also want to mention something that, people ask me for cancer advice, and depending on what's going on in their cancer treatment or disease, I often recommend that they ask about having a palliative care team as part of their care. So I just want to mention what palliative care is, if you haven't heard of it. One of my favorite leaders in the medical community, Steve Pantelat, says, palliative care, you don't know what it is, but you want it, which is, I'll tell you what it is. It's a new medical specialty that grew up over the past 30 years or so in healthcare to meet an unmet need. And it's not for only people who are dying or who know that they're dying. Hospice, for people who have a prognosis of 6 months or less to live. Hospice is a tiny piece of palliative care, and then a lot of people see a palliative care team and are nowhere close to dying, and actually don't even necessarily have cancer. It can be for other things too, like Parkinson's disease, heart failure, kidney problems, emphysema, any disease or illness that's causing symptoms that are difficult to manage or stress that is difficult to manage. And the team usually includes a doctor or another healthcare provider, nurses, chaplains, social workers. So anything from finances to not knowing how to talk to your family about something, to not sleeping well at night from worry or pain or breathlessness, anything. They are a specialty that's specifically focused on the quality of your life while you're doing medical treatments or facing something, and they're fabulous. So there's a lot of misunderstanding about what they are, and people associate them with being really sick or being close to dying, and that's actually a myth. So I always tell people, try to get that team on board if you can ask for a referral. If it's okay, I want to do a round robin quickly about this other thing that Amy was alluding to, which is clinical trials. What are they? What are they not? And when I ask the panelists to get an idea of what advice they plan to give from their heart to people in their lives or you, almost all of them said, oh yeah, and also clinical trials. So if you don't mind just giving like a quick description of why you think clinical trials are important, in particular for individual people who are choosing whether to do one. We know they're important for research. If you have anything particular to say, and then we'll do that round robin, and then we'll take questions.
Sure. Well, as somebody who's been designing and leading clinical trials for many years, the first message I would give you is that these are highly regulated. If a clinical trial is being done in the United States, the Food and Drug Administration reviews the protocols before it starts. It's also reviewed locally by an institutional review board, and so there are many checks and balances to make sure that the patients are protected and that all safety findings or adverse events are reported immediately when they occur. So the oversight of these clinical trials is excellent. The days of guinea pig are long gone, that these are very stringently run and can actually offer you extraordinary care that you can't get elsewhere. And I think this financial toxicity is a great reason too. You can get very good care that's for free because it's part of a trial. Probably the biggest reasons to participate in clinical trials outside of just the moral motivation of trying to advance research is because it takes a very long time to develop new medicines. There are many phases, and a very short time is 7 years. On average, it takes 10 to 15 years to develop a new medicine. Now, in oncology and cancer care, it's getting faster and faster, but some of the best new treatments are only available in clinical trials, which is why I would encourage everyone to at least consider it. If there's a great approved option for you, great, you should take that. But if your options aren't so good, there may be a better option available in clinical trials. I work, for example, on the board of directors for a company called Blueprint Medicine, which is developing new treatments for very targeted mutations. And so they now have drugs in clinical trials that aren't approved yet that can be very effective for certain mutations. And so that might be a case, if you have one of those tumors, clinical trials might be right for you. If you have breast cancer that's very well established and there are great approved treatments for that, you may not want a clinical trial, you may want an approved treatment, but you have to inform yourself. Again, what's the standard of care approved treatment? What are the options in clinical trials? And consider all of them, and then with your patient-centered physician, make the choice that's best for you.
There are two things I would just like to address regarding clinical trials. The first is safety, and the second is the benefit. As you've heard in general, before these drugs make it to humans, we in the lab, we do several experiments. So we try it, with other smaller animals and all the like. So it cannot really make it to even a phase 1 clinical trial if we are seeing toxicity in the laboratory. So what I will do, for example, is that we have human cells that will grow in the laboratory. Then we actually try, all those different medications and to see if there's some toxicity or not. So these are highly regulated processes that we go through in the laboratory or in the field during the clinical trial itself. So, when my friends say, I don't want to be a guinea pig, no, you're not a guinea pig. These things have been tested, all right, before going into humans. And you have a safety monitoring board. Immediately they begin to report certain adverse effects, they can stop the clinical trial. So don't fear to get into clinical trial. And secondly, the benefit. I had my friends back then in Cameroon, Africa. He was sick of malaria, and they're like, oh, would you like to participate in clinical trial? And he had to call me. Oh, no, I don't want to participate. I don't want to be a guinea pig. Then I gave you an example. Last time you had malaria, what did they give you? They gave you Coartem or quinine, right? Yeah. He said, yes, I took it. I said, some other people also went through clinical trial for that medication to be available. And that medication benefited you when you had malaria last time. At times, we don't have to be very selfish. At times, we have to understand that we've benefited from medications that other people went through for clinical trial. So please, that should motivate you to be able to go in for clinical trial. It may not benefit you immediately, but it can benefit your granddaughter.
So from the patient standpoint, I agree that the one tangible benefit is to get access to treatments that are currently not available in any other way because they have not been approved by the FDA, because they've not been tested and shown to be beneficial. So the only way to get access to something like that is through a trial. Now, I think it's important to recognize that there's different kinds of trials. The one many of us think about is the one where half the patients get a placebo or a sugar pill and the other half of the patients get the exciting drug. But that's only one kind of trial. There's a lot of trials where everybody gets the new drug. There's a lot of trials that give no drug, but that are testing new diagnostic tests, like what Kenji and I described, that just would involve maybe donating urine or blood. There's many, many ways to participate. And as a physician who, as I mentioned, I've run many trials, and I pretty much offer every one of my patients the opportunity to participate in a trial if I have one available that fits their case. And I'd have to say the vast majority of patients are happy, it's my experience, are happy to participate, and in large part seem to want to participate because of the idea of advancing the field. And that's one of the most rewarding things as a physician, to treat patients that are facing one of the most difficult times, if not the most difficult time in their lives, but then to see all this graciousness and really grace that we see every day in the hospitals.
Yeah, I agree. The extent to which cancer patients are altruistic is incredible. And I think, you see that perhaps more in that patient population than anywhere else, that people want to, contribute to the benefit of those that come after them. It's one of the challenges I face, really working with these patient groups, is balancing the the needs of those who are doing well and stable with their disease and are in it for kind of the long haul and want to leave a legacy and contribute to the betterment of research, and then those who are very much in the acute, urgent stages of what are you going to do to save my life, and so I have to kind of ride that line on a regular basis, daily. But even in Georgia, we kind of launched a sister organization that we called the Georgia Center for Oncology Research and Education, and that was to create a statewide network of oncologists through which we could deploy cancer trials and get those out to the people. Because what we realize is that 80% of cancer care is delivered in the local community. Often people don't have the desire or the resources to travel long distances to major academic medical centers, and we know that people do better when they're treated close to home and family and kind of have that support network in place. But, to reiterate some of the prior points, there's such oversight and regulation of clinical trials that you're going to be watched like a hawk, on that study. And so we know that participation in clinical trials does correlate with improved outcomes for patients. And so Blueprint Medicines, they have an amazing drug for lung cancer for a mutation called RET. And the data, it's hard to describe data as beautiful, but the data is beautiful. It melts away tumors. It is impressive. And so, that is not to be underestimated, the impact, not just for patients, but the impact to the field. And so it's hugely beneficial for all involved. And we believe strongly in it. And part of our organization is we have a dedicated navigation program and staff members. So you can call into our organization, and we have a program called Lung Match, where we will help navigate you and help you find appropriate clinical trials. So, it's as simple as picking up the phone, but, navigation is another piece that I think we talked about earlier. Find those people. There are trained, what we call nurse navigators, who are, very well versed on the science and the trials. There are lay navigators, patients who have gone through cancer themselves and can walk alongside you, but find those people who can help you identify those resources and take full advantage of them and make, we call it shared decision making. So that's kind of the model of working with your treatment team to make decisions that meet your needs as a patient. But yeah, it's hugely important.
Every physician does do clinical trials, and so you may be seeing somebody who doesn't know about clinical trials, but all companies list their clinical trials on a website known as clinicaltrials.gov. And so if you search online, you can find any trial, and you can search by your specific type of cancer and find out where they might be going on and how you can get more information.
That's great. I was going to ask to clarify that, and I think once you find that information, you could bring it to your own doctor, or you could check it through a foundation, like the Go-To Foundation for Lung Cancer, whatever the particular cancer is. Our family participated in 3 clinical trials, at least. One was a clinical trial for a treatment, the kind that you might picture, where you're trying a new treatment and they're keeping track of how it's going. Paul was also in a trial through Dr. Moore's foundation, the Go-To Foundation, where all it was web surveys about what was going on in his past history and health, and then we gave Stanford Hospital permission to take the extra tissue samples so that they could use that as part of the study. So that we did from the comfort of like our sofa or bedroom or whatever. And then we also were in a clinical trial that was about couples counseling at the cancer center. And that was like, well, it's for the good of science, so I'll go to couples counseling with you, which was like pretty funny. And so there's many, as you can see, there's many different types of research that are happening, some for treatments, some for types of testing, or even other support. So pay attention to those, and I think they're great.
I would just kind of follow up on that. And because we have made so many advances, we now have a significant number of cancer survivors in our country. And so there's a whole field that has kind of risen up around that, survivorship. So you are defined as a survivor from the moment of diagnosis through the balance of one's life, So that is kind of how we refer to it now. And, beyond just the treatments, there's a whole piece and body of literature around like all the psychosocial pieces. What are the emotional needs and challenges facing patients. And it may be, that encompasses so much space, but it may be transportation needs. It may be, just everything, financial concerns. There's a whole wealth of information, but yeah, survivorship has become a big, kind of defined research space in of itself. And that's really a testament to where we are in the field, that it's a great thing. And, for some cancers, we are and have achieved a quote cure. And now I think for others, such as lung cancer, where the 5-year survival still hovers around 18%, we're trying to move that needle to say, can we, through the combination of these various approaches and innovations, can we start to approach it more as a chronic disease? Can we maintain quality of life and have enough treatments kind of in our armamentarium to keep people going for a number of years? So that is also kind of the shift. Will we, there are some cancers we think of, pancreatic, everybody's heard about Alex Trebek's got stage 4 pancreatic cancer, and that has been one of the graver forms of cancer for reasons that we don't fully understand. It's harder to, there aren't good screening methods. For example, lung cancer remains, low survival. There are some challenges like that, and there are others like breast cancer where, we've made significant progress. So, that's just one thing I reinforce. Well, there's survivorship piece, but again, advocating for continued funding for research, because we have tremendous momentum. We don't want to lose it, so, yeah.
Great. Thank you. So we have up to half an hour to take questions from anybody who might have one, and I think Pastor Kurt will take a mic and come around. Feel free to address it to the whole panel, to a particular specialist, whatever you might want to ask.
I'm Kay Moeller, and I'm a nurse. I'm wondering how close we're getting to being able to discern whether the prostate cancer that someone might have is aggressive or pretty benign and is going to grow very slowly. And it seems like in the medical community, at least in our experience, that they feel, particularly with the folks that are getting older, like 70s and 80s, that if you live long enough as a male, you're going to end up with prostate cancer anyway, but you'll probably die of something else. And based on that philosophy, then, as you get older, they don't want to do a prostate exam, they don't want to do a PSA test. The philosophy is, well, if we find something and we end up doing surgery, and we may end up doing more harm than good. It's a real dilemma, because I think the more you involve people in their care, I think is helpful to them, and to put up a roadblock and say, well, we're not even going to do a prostate exam, we're not even going to do a PSA test, when you might be one of the unlucky ones that ends up with something that is aggressive, even though you are older. So I'm really interested in knowing, are we getting pretty close to knowing which cancers, either based on a liquid biopsy or a regular biopsy, is really going to be aggressive or not? And what do you think about that philosophy as people are older about not doing a prostate exam or a PSA test?
Okay, so I think we're going to tag team on this question. So I'm hearing one of the questions you're asking, I think, is that one. How do you advocate for screening versus not? How do you make a decision when your doctor's talking about risks and benefits of screening? And as an example, for prostate cancer, the biopsies or removing the prostate or prostatectomy can have side effects, such as erectile dysfunction or incontinence, that are really hard to live with. And so there's some trade-offs about whether to do biopsies and treatments if a cancer is really slow growing, or if it's even borderline, whether it's cancer or not. So there's been this idea that if the PSA test were getting judged as like whether it's a good cancer screening, it probably wouldn't have been accepted or approved. So it may even have been that it was an overcall to call it an official cancer screening. That said, For some people who are at high risk or who have a preference to get screened, who would be willing to take a particular trade-off, it may be worth it to them. Sleep better at night, feel less worried, whatever it might be. And so the current recommendation for PSA screening or for rectal exam screening to check the prostate is shared decision making, which is what Dr. Moore and Dr. Dean, actually everybody, talked about today, which is tailoring your medical care to what fits you and your values and your risk tolerance and the types of factors that come with you as a person into the discussion with your provider. So the official recommendation for that is shared decision making is how you decide whether to do prostate screening, compared to a stronger recommendation like a pap smear over this period of time, a mammogram, a colonoscopy. Those are a little more based in a definite population benefit compared to risk. So that's what I would say about that as a primary care doctor. And I think maybe what each of us would say is what I think you're implying, which is making sure that you have a provider and your provider is listening to what you are bringing to that encounter and feeling like is best for you. And also feeling like you have enough information so that you can make the decision from them. But I think this is an interesting example, right? You're a nurse and it's still kind of hard to work within the healthcare system. And so I often think about how intimidating that feels if you don't have a degree like that or like ours, So anyway, that's kind of my tone setting for that. And if there's anything you want to add, you can also feel free. I'll pass it to Dr. Seeley too on the science question of how close are we getting to really delineating those risks even more and knowing which abnormal prostate biopsies matter and which ones are less concerning, but still anxiety provoking.
Yeah, and I don't think I have the perfect answer, but prostate cancer is lagging a little bit behind, but I do think the answer is in the same genetic signatures where other fields are moving. So I am certain that prostate cancer is not all homogeneous. A lot of it is slower growing and not very aggressive, but occasionally, and maybe in younger men in particular, you can get very aggressive prostate cancers. And even the slow-growing ones over time can turn into aggressive disease. And so these genetic signatures and these mutations, which happen over time, will be able to guide us as we learn more. Today, I think we're all aligned that no matter what the disease in general, less treatment that you can get away with is good, because all treatments could have complications, and prostate cancer is the same. I think we are learning more, but right now we sort of treat it as a group. All prostate cancer is sort of the same, and then over time, if it starts to have more aggressive behaviors, it's growing faster, the PSA is rising faster than others, we will start to treat it more aggressively. So we're not at the level research-wise, either in diagnosis or really segmenting out the various mutations, but I think it's coming. I don't know if you want to.
There's a lot of research in this area on the molecular properties of prostate cancers, which might predict whether they can just be left alone or whether they need to be treated. And we're not there yet, but any month or any year could be the big breakthrough. This is one of these things that we're looking for at the conferences. I do have to say that its management of prostate cancer has changed dramatically in the 10, 15 years I've been in oncology, where now many men undergo what's called active surveillance, which is not treating the cancer, but the active part is critical, which means usually every year or two having repeat prostate biopsies to resample the tumor to make sure it hasn't changed. And if it still looks slow growing, then the men can continue without treatment. But if it changes, then one would intervene. The idea being that way you might be able to, most men can avoid treatment, but then you catch the ones that need treatment early. So there's many trials in this area actually, and one of the exciting areas I think where we will see progress over the next 5 years.
Hi, I'm Mary Harris, and thank you for clarifying the clinical trial aspect, because I too thought it was either a placebo or a real drug, and so that's made me feel a lot better. I have cholangiocarcinoma, and I get about 8 weeks, I get a CA19 test, which I guess is a marker test, and I haven't actually taken the time to know what that is. I just know the number's dropping drastically, which makes me happy. But I think I'd like to know a little bit more about the science behind the marker and what that actually means.
CA19-9. Yeah, so CA19-9 is a protein marker that's made by some cancer types, including sometimes cholangiocarcinoma. It's something that the cancer cell makes and excretes into the blood. So, and that's why you can get a blood test where they look for this particular protein, and it can be a way of tracking how the cancer is responding to treatment. And so going down is exactly what you want to see. So it's really encouraging, and I'm very happy to hear that. And so it in a way falls into this liquid biopsy, aka blood test category. It is one of the original ones. It's been around for many decades. It doesn't work for a lot of cancers, but it turns out for a subset of cholangiomas it does work. So if it's an option for you and it's working for you, that's a great way to track your response. Right, it can bounce. The issue is, unlike the mutations I talked about, that we track in the newer kind of liquid biopsies, which are really only coming from the cancer, there are other cells, healthy cells in your body that can also make CA19-9. And so that's why it may never go to zero, because some of your healthy cells are making it, and how much each of us make in our healthy cells is different. And so that's why it can fluctuate. So it's not only coming from the cancer. When the levels are really high, it's likely the majority is coming from the cancer. And so then as that is dropping, that is a very good sign.
That's a problem with biomarkers in general in the laboratory, because one biomarker can signify two different types of diseases, or maybe two different types of cells can produce in that specific type of biomarker. So that's why it plays along with the specificity of a test. So one of those good things I really want to see in a test is how specific that test is, because you could say, oh, it's dropping down, or it's being elevated, but probably it's being produced by another side of the body. So it's a general thing in terms of developing an assay, and all those things, try to identify how specific, it could be in particular.
Thanks. I'm Holly Hayashida. I'm a member of this church, and I have no credentials other than that's relevant to this conversation. And maybe my question is really more appropriate for a longer conversation with one or more of you, which I guess since you're all members of this church, I have an opportunity to perhaps have a little shout out for the church. My question really is, it seems like a lot of American medicine is really sort of driven by for-profit pharmaceutical companies who are behind a lot of these drugs that are, it sounds like, making great strides and inroads in treating cancers. And I have a slight nervousness, I guess, about that maybe there are other treatments that are not related to pharmaceuticals that we're not really, in this country, we're not really pursuing, because the money is really coming out of pharmaceutical companies. And so I guess I'm wondering, and again, maybe this is a longer conversation, but I'm wondering about, to what extent is American medicine in conversation with people, with medical specialists in other countries? And I feel like if I tomorrow go to my doctor and come home with a terrible diagnosis, I'm not going to have time to research all that other stuff, and I'm probably going to go with whatever's in front of me. But I'm interested in to what extent American medicine is learning from what may be happening in other countries, because I do understand that some other countries, in fact, have better outcomes than for certain cancers than we do in this country. So maybe you can take a piece of that.
I'll start. There is a whole field called complementary and alternative medicine, or CAM approaches, which I think in the cancer space, includes acupuncture, more holistic therapies that are often a complement to more standard approaches. And the first CAM conference I went to, I have to admit, I was a little skeptical, because I am hardcore basic scientist, that's my pedigree. But I was really impressed by the scientific rigor of what was presented. And, I have heard it from friends and family myself that, we really know the cure to cancer, and it's just we're lining the pockets, and they're not going to share it with the public because they just want to keep making money. That's what I hear on a regular basis from various people. And so we work closely with pharmaceutical companies. I mean, straight up, we get funding from them. And, our standard response is, well, when the federal government starts funding lung cancer to the extent that it funds breast cancer or some others, then we'll be happy to let that go. But until then, we're going to take money from whoever is willing to give it to us to help patients. That being said, I think many of those companies do work with patients. They have them on their advisory panels. They work with them in shaping and designing their studies. So, and they have learned their lessons. I used to teach a college class based on the book, The Emperor of All Maladies, A Biography of Cancer, which is a great book that's fairly accessible to the lay public, but there's a great section on the creation of Herceptin, which was a targeted drug for breast cancer, and some of the patients kind of en masse went to the company and petitioned for access to this drug. And so because of that, companies now realize we have to include patients in our processes and stuff. But I think there's more of non-traditional approaches being incorporated into cancer treatment. And certainly, I always say I'm a doctor, but not the kind that helps people. I'm not an MD, so they probably know more along those lines than I. But we are seeing that.
I was just going to say that, of course, companies are interested in drugs that are on patent because that's, again, how we have protection for all the investment we have to make to develop them. But it's also very important to know that groups like the National Institutes of Health have huge screening efforts looking for drugs that are in the public domain that may have been missed and that could be used. And so I do think there is a large research effort going on in this company for things which are already off patent that could be repurposed and used for new uses, which is really important. And then now more than ever, there is global collaboration in terms of developing new medicines with China, with Japan and Asia, more so than ever before. So it's not perfect, but I think we are seeing much more the globalization of medicines, and not just on patent medicines from the pharmaceutical company.
And you want to?
Is that on? Yeah. I was just going to make a comment about that question and the wisdom in that question, like profiteering aside, which is it's not necessarily that more intensive treatment is better. Like 3 chemo drugs aren't always better than 2, or being in the intensive care unit isn't always better than being at home. And that includes what your actual outcomes are in terms of how you feel, what your functioning level is, and even how long you live. There's this sort of throws a thorn in the whole thing, but there's a really famous study in the New England Journal of Medicine around 2012, and it's in patients who have stage 3 or stage 4 lung cancer. So lung cancer that has already spread from the lungs to somewhere else in the body. And the patients in that study this is a plug for palliative care, which is, again, like one of my favorite medical specialties. The patients in that study were randomized in a clinical trial between routine oncology care with all the usual medications and treatments and routine oncology care with usual medications and treatments plus a palliative care support team. And the people who had the palliative care support had better outcomes in terms of less depression. They actually were hospitalized less, and they did a little bit less aggressive treatment than the other people because they had this additional team helping them weigh the benefits. But they actually lived longer than the usual care group, which is kind of really interesting. So I think it is really important to tease out not just how intensive your treatment can be, but those trade-offs in terms of how it can actually make your body less strong, or anyway, that additional support and sort of teasing out what's really going to work. And I want to recommend a book, actually, in that vein. There's a really good book. It's pretty thick, but it has different reference sections. It's called Living with Cancer, and it's written by a team at Massachusetts General Hospital, and it has chapters on like everything across cancer care, including what Holly's talking about, complementary and alternative medicine, and how to think about big decisions in cancer care. So Living with Cancer is a really good reference.
Yep. So I just say a couple things to that also. I think it's a great question. I think it's true that most of the trials are funded by pharma, and therefore they're done on the new drugs that pharma's developing. But the NIH and other government institutions do fund other trials that are not related to new drugs, including alternative medicines. For example, we participated in a trial a few years ago of using manuka honey during radiotherapy for lung cancer, because there's some evidence that this might reduce side effects. And so that was a randomized trial using that alternative approach, which came from some data that actually was generated in Australia. And there is a lot of interaction between international cancer researchers, and more so now than ever before. We meet at the big international conferences. A lot of those, of course, are in the US, but there are a lot that are international. I serve on some of the committees for those where we select the abstracts that get presented, that get the high-profile slots, and there's no pharma representatives on those. It's just academic physicians, and we pick the abstracts that show the biggest benefit. So if the abstract were, some vitamin cures lung cancer, that would be the number one abstract we would allow to present, and if I had that result, I would absolutely treat my patients with that. So I think you're absolutely right that there could be more money spent on that, and that's, the problem is where does that money come from? So that's the main thing that limits it, but there is some research, and I can assure you that if there were such advances, that physicians would absolutely give those to their patients.
I'll just give you a global perspective, coming from a developing country. I've been one of those people that has gone behind the pharmaceutical companies because we always have what is called neglected tropical diseases. The pharma, they go behind the money. But I think advocacy really helps. I'll give you the case of HIV. Sorry, I'm going a little bit out of cancer. When HIV started, for us there in Africa, only the rich could afford the medication. Even to do your CD4 cell count or your viral load, only the rich could afford. So the poor, it was difficult to manage them because they could not afford that. But with advocacy and everything, HIV treatment in my country now is virtually free. Testing for malaria in children less than 5 years is free of charge. You walk into the hospital and they test it free. All those is because of advocacy. So one of those, the best way to go behind the pharmaceutical company is, form groups, go behind them, knock on the doors. It takes some time, but after some time the message will go through.
To piggyback on that a little bit, do you have in your view of the broader research information on food as medicine?
I can speak partly to that. When I was in Georgia, we helped fund an investigator at Emory University who focused on the area of chemoprevention through food and prostate cancer. So he was looking at things like turmeric, as an example. And then I worked with a radiation oncologist at a community cancer center in Northwest Georgia who, was very much an advocate for dietary pieces to, the equation. And, I do think there is evidence that, merits. And we know, if we did the things we know we should do, we could prevent at least a third of cancers, right? Exercise, protecting ourselves from the sun, maintaining a healthy lifestyle. So the dietary piece, a lot of people are looking at the role of sugars in cancer now, something called the Warburg effect in cancer metabolism, kind of, the energy of the cell. And is there a role for sugar? There was a story on CNN the other day, like the consumption of one sugary drink a day may increase. That's kind of, I don't know, that was a well-designed study, but it's certainly a line of investigation in looking at that. But mm-hmm. Mm-hmm.
So the short answer is we don't have strong data that tells us you eat this food or that food, it will help or hurt. We have some hints and suggestions from various studies, but those studies generally they're not the randomized kind where we can be pretty certain that that's the cause. There could be many other factors that we're not able to track that might contribute. So part of the difficulty that you're voicing is that the medical we don't know what the right answer is, and then that makes it hard to give advice. But what I would advise my patients, I get this question a lot, is, and I help them and see a nutritionist as part of their, actually usually very early during their care, but whenever the question comes up, sometimes it comes up during the surveillance, 3 years after I've treated them. We have nutritionists, and most cancer centers will. who specialize in this and what you can do with your diet and what the latest guidelines and data are. And so I think that's something I'd encourage you to consider is maybe ask for a referral to a nutritionist who particularly specializes in patients with cancer, and that could be very helpful. There is some research. Part, again, is the funding. That research is not funded, right, by pharmaceutical companies. There's no drugs. It has to be funded by things like the NIH or other government organizations or philanthropic organizations. And there is research. It absolutely is. I think part of the challenge is those are very difficult studies to do, because to really get a true answer, like the bar that the FDA sets for getting a new cancer drug approved, is you have to generally do a randomized trial to prove that the drug is better than either placebo or whatever was done before. To do that with food is very difficult, because how do you get patients to only eat one thing, or right? So you basically have to force people on a certain diet, and likely for many years. That it's very challenging to design such a study, and it would be very expensive. I think that's part of the reality of why we haven't made more progress. It's a sort of a structural difficulty.
For one or two more.
Karen Gernand, and I have two questions. One of them's really quick, I think. And that one is, can anybody participate in a trial, even if you aren't diagnosed with cancer? I'm thinking of Max's, the liquid biopsy, if that would be useful. I'm a twin, and I do twin studies, so sometimes they need the person who doesn't smoke, or, whatever. And then the other question is, because I'm not a scientist and I'm a little bit ignorant, happy not to know about this, but is cancer just an abnormal growth of genetic material? And how is that different from genetic disorder?
So as far as clinical trials, there would be multiple ways to participate. There are, of course, clinical trials in every area of medicine, so it doesn't have to be cancer. So if someone is a non-cancer patient, there might be something else that they would qualify for because of whatever their health status is. Particularly for cancer-based trials, the easiest way I could imagine a non-cancer patient participating would be in a screening type study, where one is trying to test if a new test, let's say a PSA, a new version of the PSA test, or a new liquid biopsy, is useful for catching a cancer early. There's always such studies going on in various sites, so that's what one could look for, like a cancer screening study. As the biological question, the difference between a cancer and a genetic disorder, what I assume you're referring to is a genetic disorder is generally something we think is something that we're born with, that's in with our DNA, that all of our cells have, that is passed on to us from our mother and father, and therefore it's already in the cells when we're born. Cancers in general form after we're born, and our cells acquire new mutations that weren't there at birth that then get acquired as we age. What happens is that our cells have to divide and make copies of themselves to renew our tissues continuously. And as they do that, they have to copy the DNA, the genetic material in our cells. They have to copy a string of letters that's 3 billion letters long. And their cells are extremely good at it, but they make a few mistakes every time they divide. And if they make a mistake, in most places it makes no difference. The cell is totally fine, will not be cancer. But if it makes a mistake in the wrong place, it could set the path towards having a cancer 10, 20, 30 years later. So it's really, it's part of aging. Most, I'm talking now cancers in adults, not children, of course, but most cancers form in adults later in life, and it's because of this. It's a phenomena as our cells acquire mistakes as we age. It's part of our biology, and so that's how it differs from something one might be born with, some genetic illness versus a cancer. But ultimately, the problem is in the DNA in both cases.
Okay. So participating in clinical trial actually depends on the study design. For us, we have a study now that is exclusively for people who have been diagnosed already with this particular cancer. We also, even though you've been diagnosed, at times we need to use the sequencing data, especially pharmaceutical companies that use our data. They need to still use the sequencing data to actually enroll certain patients into the study. So it all depends on the outcome of the study. So they may say that, all right, even though this patient has this cancer, but the patient cannot still enroll in the study because the genes that they are looking for may be a little bit, or may become a confounder in the study and all those things.
has these large-scale cohort studies where they're enrolling, tens of thousands of people and plan to track them over many, many years to try to identify what are underlying risk factors. I mean, that gets back to some of the stuff that Max was alluding to with the food piece. If you're trying to look for causes of cancer, it's hard often to sort that out without looking at a lot of people, a lot of exposures. And so, but that's another potential opportunity that you can check out is through like the American Cancer Society.
One more?
I'm Pat. Thank you for all the wonderful information. I've had both lung cancer and breast cancer. I'm fine. They were discreet.
You talking the mic?
Oh, I said I've had both lung cancer and breast cancer. What? Oh, okay. Hello, everybody. Start over. You two gentlemen probably have little pieces of me in your lab because I signed the papers. I hope it helps, but anyway, I'm fine. Everything is good. But you mentioned the Bonnie Adero Foundation, and I just wanted to say something about that. When I was first diagnosed with lung cancer, I told a friend, she told a friend who told a friend of a friend. I got a phone call from a nice lady who said, I had cancer 15 years ago, lung cancer, and I'd like to come bring you the handbook. Okay, never saw her before. And this lovely, robust lady comes bouncing up my steps, gives me the handbook. All I want to say is if you get a diagnosis of lung cancer, I went into it almost fearless. I had all of my questions answered. I studied the book, and it's a wonderful, wonderful organization. And she's right here in San Carlos, and it's nationwide. Thank you.
Bonnie is incredible. She is a tour de force. She was diagnosed herself in 2003, stage 3B, and her doctors basically told her to go get her affairs in order, that it was wrapped around her aorta. There was basically nothing they could do, but she wasn't going to take that. Knowing Bonnie, she's not the kind that just does that and goes politely away. She dug in, and she found somebody who could help her. So she found a doctor at UCSF who said, I'm going to take you to the brink. I'm going to hit you with as much chemo and radiation, which was what we had at the time. And it may kill you, but you're going to die if I don't. And so he wanted to shrink it. And he said, if I can shrink it enough, I think I can get it out. So she had this grueling surgery. And then, she came out of it. And then in 2006, it was right around the time that Dana Reeve, who had been Superman's wife, had passed away. You might remember that story that Dana Reeve, the wife of Christopher Reeve, passed away from lung cancer. And Bonnie just said, enough. I've got to start a foundation. She'd been a hugely successful CEO. And she's like, I'm tired of the status quo. I'm tired of going, no offense to Stanford, I'm tired of going to places where it's gray walls, gray people, like there's no life left in the room. I want to do something to help. And so, here she is, still alive after, being diagnosed in 2003, and she's created, when I moved here, I was looking for a job. I'm like, oh, there's this little family foundation in San Carlos, I can stay close to my kids. It's a worldwide phenomenon. I mean, it's incredible what she has created. And so, yeah, it's right here in San Carlos, right down the street, and it's amazing. So, yeah, it just takes one person, to like make a difference, and, then it becomes a wave. And so it's great.
You are all amazing. Thank you for doing this panel. Let's give them a round of applause.
Thank you all so much. I said at the beginning of this time that it's a joy and an honor and a privilege to spend time with families in the hospital and by the bedside. And oftentimes I end up praying for healing, but I also pray for the persons in the room because it's obvious to me that healing happens through the work that you all are doing and your shared work that you've been called to do. So thank you for everything you're doing. And would you just join me in a quick prayer for them? Oh, this was live streamed, so if you'd like to watch it back again, you can watch it back later on our Facebook page, Trinity Presbyterian Church on Facebook. Find us. Let me say a little quick prayer for them. Gracious God, I give you thanks for the work that Amy, Max, Kenji, Lynn, and Lucy are doing, and all the other people in this community and at large. God, will you fill them with your energy, imagination, and intelligence to be good stewards of the callings that they have, God. May you meet them in their work as they participate in being a healing presence through all the ways that you have gifted them, God. Bless them, and may you come alongside persons who are diagnosed with cancers and their families, God, and will you be a present help to them in their time of need. We pray this in Jesus' name. Amen. Amen, everyone. Thank you for coming. Thank you.